Good afternoon, everyone. I'm here to present my 6 months progress of my PhD, titled as Residual Symptoms Following Total Knee Arthroplasty. I'm András Zoltán Posta. I'm currently working at Orthopedic Clinic Semmelweis University, and as well, I am a first-year student of CTM's class of Cardio and Sports Science. Here I want to seize the opportunity to thank for all of my supervisors and team for all of their help, because without them I couldn't stand here today. As a resident working in orthopedics, I have a clear vision to operate people with osteoarthritis the best possible way, and to do that, I want to study the different techniques of total knee arthroplasty. I have 2 ongoing projects. We started the first one in September 2024, and the second one just 3 months later. My first project is investigating the effect of Esmarch tourniquet during total knee arthroplasty surgery. So osteoarthritis is a degenerative disease which can affect all the joints, but the most common in the knee joint, causing pain and stiffness, and it's a leading cause of disability in the adult population. The definitive treatment for that is total knee arthroplasty, and there are currently around 40 million adults affected just in the US with this disease, and there are around 1 million total knee arthroplasty performed yearly. This is an ever-growing number, and we have projected surgery numbers of around 2 million by 2030 and around 3.4 million by 2040. So you may ask what Esmarch tourniquet, my title, was all about. Esmarch tourniquet, you can see on the screen, it's an inflatable device which you can put it on the thigh to prevent blood flow of the operated area. So one day I was operating another surgeon, not my mentor, and I was surprised to see that he doesn't use tourniquet. After I questioned him like why he didn't use tourniquet, he said he didn't used to do it. I was surprised by this answer. I did some research, and I found out that this is the case worldwide. Like basically 60% of surgeons are using tourniquet and 40% are not, based on habitat. I think this is a really bad thing to use anything in healthcare without proving its usefulness, or at least it proven not harmful. So our aim is to assess the impact of Esmarch tourniquet during total knee arthroplasty. Our clinical question is, does the use of Esmarch tourniquet affect the short and long-term outcomes of total knee arthroplasty? Our patients are treated with total knee arthroplasty, and we are comparing operating with tourniquet to without tourniquet, and our outcomes are bleeding, pain, surgery time, and thromboembolism, and a lot more. And our hypothesis is that the usage of Esmarch tourniquet does not affect the long and short-term outcomes of total knee arthroplasty. So after proving its feasibility, we created this search key, and we did our research in 3 databases and got around 6,000 hits. With the help of my lovely teammate, Nandor, we reduced this 6,000 number to 83 eligible articles. And then we did the citation and reference chaser, and from around 2,000 hits following the same steps, we got 10 new articles to include. So here I would like to talk about the subgroups, because you have 3 main ways to use tourniquet. The first one is full tourniquet, when you apply it before the incision and release it after the suture. Then you have the half tourniquet, when you apply it before the incision and release it after the cementation process has done. And then you have the cementation tourniquet, when you inflate it just before the cementation and deflate it right after. So we have studies to compare these subgroups to each other and to no tourniquet group. For now, we analyzed the full tourniquet to no tourniquet, and then we would like to do a network between all the subgroups. I will show the results of comparing full tourniquet to no tourniquet. So first you have surgery time. Surgery time is really important, because right now we are operating because we think that's easier to operate in a bloodless surgery field. And to measure easy, it's the basic way to measure surgery time, the objective way. So here we included 19 RCTs with around 2,000 patients. We got high heterogeneity, which could be caused by the different decades of publication, different surgeons, or different approaches. But the main thing is that it's only 3 minutes shorter to operate with full tourniquet. It's mathematically significant, but from clinical standpoint, not that much, even if you know that to apply tourniquet, it's around 15 minutes. So basically, operating with tourniquet, it's longer if you add the time of the application. Secondly, here we have risk of transfusion. This is really important because if you want an objective measurement of blood loss, you can look into transfusion. And here we included 16 RCTs with around 1,800 patients. And we got a moderate heterogeneity, and the result that we have 30% higher risk of transfusion with full tourniquet. This is mathematically not significant because from clinical standpoint, it's really important. But here we have risk of deep vein thrombosis. It's really important because the deep vein thrombosis could kill a patient. And here we included 15 RCTs with around 1,600 hits. And we got that it's 63% higher risk of DVT with the use of full tourniquet, which is from clinically, it's really important, and from mathematically, it's significant as well. So as a conclusion, the use of full tourniquet reduced slightly the surgery time. However, it increased the risk of transfusion and DVT. So we don't really recommend to use full tourniquet in the future. On the screen, you can see my first project progress. As you can see, I finished data extraction, and we are right now at the risk of bias and data analysis phase. Let's jump to the second project. It's assessing the effect of preoperative biomarkers on postoperative outcomes in patients undergoing total knee replacement. So as I mentioned, there are a lot of total knee arthroplasties going on around the world, but what I didn't say, that around 1 from every 4 patients is unhappy with the result. We noticed something at our clinic, that there are a subgroup of patients who are coming in with really high pain and really low objective symptoms, and then we have a really easy operation, and they have a higher likelihood of residual pain. So we thought about this, and so right now there are long waiting lists for total knee arthroplasties, and we operate basically because of the pain. And if there is some subgroup of the patients who are having pain after the surgery, maybe we don't need to operate them, but we can treat them conservatively. So our aim is to create a predictive score to estimate the likelihood of this residual pain based on the patient's preoperative data. Our clinical question is that does preoperative data predict residual pain at 3 and 6 months post-surgery in patients undergoing total knee arthroplasty? Our factors are preoperative data, and our outcomes are residual pain at 3 and 6 months. And our hypothesis is that high preoperative pain scale scores combine good range of motion and low X-ray scores are associated with higher likelihood of residual postoperative pain. So as a summary, I have 2 ongoing projects. We started both of them in September and November 2024, and we would like to submit the first one in September 2025 and second one a year after. So I would like to finish my presentation with the words of Weiner from Brown. Research is what I'm doing when I don't know what I'm doing. Thank you for your attention.
Excellent projects. Congratulations there.
So seeing the, first of all, beautiful presentation.
Thank you.
Really well done. Do you think the pressure of the tourniquet influences the outcomes? What are you seeing in the literature?
Yes, so I think it matters. So basically, higher the tourniquet pressure is, you can apply it in different pressures, like systolic plus 100 or to 350 or something like that. So higher the pressure is, the more likely the pain would have pain in postoperative first, second, and third day. But we didn't had mathematical significance, so I wouldn't show that figure.
Brilliant, brilliant presentation. Thank you. These figures were new. I think you have just finished data extraction or something like, or the statistician gave you the figures back. So this is interesting. If you use full tourniquet, then the patients need more likely transfusion. Why?
Yes, because as I said, with full tourniquet, you inflate it before the incision and deflate it after the suture. So you don't have the chance to electrocoagulate the bleeding. But with no tourniquet, when you cut and you see a bleeding, you can electrocoagulate. So this is why with full tourniquet we have more transfusions.
I have a question too. First, great work, impressive. I have a question about the second project. What kind of data could predict the post-operative pain? What are you thinking exactly, like in examples?
Yeah, like we try to do a predictive score based on the pain and the objective symptoms, which is X-ray scores and range of motion. And from that, you can, like, if we are right, from that you can predict the postoperative pain. So from these two things, or these three things. We will measure a lot of other things like comorbidities and a lot of other things, but I think this is the most important because it could be because of the pain resilience the patient has. Yep.
Thank you.
Congratulations. First of all, I really like this project because it want to break that highest level of evidence we do this in that way, so nobody question why. I like this. But the second thing is regarding your first project, there was a pretty high difference between the embolism, 64% difference, I think.
Yes.
Do you collect this? Is there any difference between the post-operative thromboembolism prophylaxis? Because it is an important factor in this question.
Yes, so I was thinking about this as well. Basically, you can see that it's our studies, included studies, are from 25 years. And in the 25 years and different countries and different hospitals, they are using different antithrombotic antithrombotic prophylaxis. But we didn't really find the difference between the publication date. So I don't know. And they didn't mention in every article what did they use. So we don't know.
I have a question regarding your first project. So is there any available guideline about using tourniquet?
No, right now we are using tourniquet only by habit. So we have no guidelines at all. If you used to do it, then you do it. If you learned from a mentor who used it, then you use it as well. So yeah, that's why we are doing this study.
Thank you.
Thank you. Last question.
Thank you for your presentation. I'm coming from the other corner of the OR as an anesthesiologist, and my question is that did they use any drugs affecting coagulation during, even locally or systematically, during the procedure, and if they did, what drugs? Like tranexamic acid or something like that?
So it's really hard because in some articles they are mentioning everything, in some articles just some details, in some articles nothing about it, like what did they use. But they are using in a lot of orthopedic surgeries TXA. Yes, so yeah, in the surgery.
And what's your practice?
We use it as well. If the anesthesiology says that we can give the patient. And we are waiting for it to arrive.
Good answer.
And we are saying we see that it didn't arrive yet. And then, yeah, we are waiting for it.
And I didn't ask him to say that before.
Thank you for presentation and your answers. Thank you.